I'm Marie Rapone from Hyde Drug Store. We're located in Newcastle. I'm a pharmacist, custom compounding pharmacist. And the first topic I wanted to talk about is low-dose naltrexone. So low-dose naltrexone is a capsule that we make. We have an in-house lab, and it's used for lots and lots of diagnoses. Here in the office for rheumatology, very popular for inflammation, fibromyalgia, inflammation, autoimmune, and not to be confused with the commercially available product. So naltrexone, which is commercially available at a much higher dose, is actually used for opioid overdosages, so not to be confused. When you custom compound it into a micro dose, now it changes the mechanism of action. Now it works differently in your body. So not to be confused with the commercially available product. And what it does, not to get too technical, I tell patients, but it stimulates your body to make more of its own endorphins. So have you ever heard when you exercise, you get a surge of an increase of endorphins? This is training your body over time to have a higher amount of endorphins in your system. And what it's showing is patients are seeing a significant reduction in inflammation over time when they take the naltrexone. And I like to state over time because it's not always quickly. And typically when you start feeling better, it comes on very subtly. You might even question yourself, like, I think I'm feeling better, before you know that you're feeling better. I do get some patients that are quick responders, and they'll call me up and they'll say, I feel great, it's been 2 weeks. Then I have other patients, it could be 2.5 to 3 months. So it's very individualized. I'm on it myself. I can tell you it took me about 2.5 months. I've been on it since 2018. And it's done wonders. So patience in the beginning is key. So what we use is a titrating dose. We titrate up. Even though we're titrating up, it's still a micro dose, so keep that in mind. So typically you'll start on, there's several ways to do it, but the most common is you start with a 1.5 milligram capsule, and you take one every day at bedtime for 2 weeks. Then you go to 2 capsules at the same time, every day at bedtime for 2 weeks, and then 3 capsules every day at bedtime thereafter. And again, it's still a microdose because some people think, oh, it's 3 capsules, but they're very small dosing. So a couple of things with that. Say you start taking it and you're a quick responder and you feel well in a couple of weeks. You may not necessarily have to go up to that next dose. It's not like when you take Tylenol, you take 1, 2, I feel even better. The lower the dose that suits the patient, that's what you stay on. If you're having a response on a 1.5, you stay on a 1.5. And that's when I tell patients, call me. I'll get a hold of your prescriber. I'll say, so-and-so's doing really good on 1.5, and they're going to tell you to stay on that 1.5 or whatever dose you're on. So that's why in the beginning, we'll give you a bottle of a lower dose for flexibility in dosing in case we have to tweak it for that first month. Side effects are mild and they're transient. They're generally just in the initial phase. And I tell people, you might get a slight headache when you first start taking it or when you increase the dose. Nothing that Tylenol shouldn't take care of, a slight headache. You might get an upset stomach, like a queasy feeling or a little nauseated in the initial phase that typically does not hang around. Vivid, colorful dreams, very, very common, vivid dreams. So it's recommended to take it at bedtime, but I get a lot of questions with this as well. Remember, it's increasing endorphins. Endorphins give you energy over time. They give you a general feeling of well-being, and like I said, they help with inflammation. But being that they give you energy, I have patients that call to tell me that they may feel like they're not sleeping as well as they normally are on the medication. So I tell them, just switch it to morning or afternoon. It's not a game changer. Just not a game changer. Just switch the time of day. We want you sleeping. Price point on it. The price point on the low-dose naltrexone, not covered on the insurance. So what we do is we offer a 90-day supply for $50. So it ends up being under $17 a month. and we ship anywhere in PA with no charge, so we have free shipping. Really, you can use any prescription medication, anything over the counter with it. The one medication that you really want to be cautious with, it's really not a drug interaction, but you have to be careful if you're on a pain medication. Remember, at higher dosages, the commercially available product stops it from working. At a lower dose, it could make it less effective. I tell patients, if you were prescribed something like that, call me, because it could be where we could just space the dosing appropriately for you, or you may not. You might have to stop that while you're on the pain med and then restart later. So you can call me up and I can guide you through that if that's the case. Do you have any questions? I think if I remembered everything.
I have a question.
Sure.
I wasn't following. I remember now when Dr. Stupai did recommend that. Why does the lower dose, why are you prescribing a lower dose and not that higher dose? Wouldn't you get more of a, hey, more is better?
Well, that's the beauty of this. It's the micro dose that changes how it works in your body, what we call the mechanism of action. So at a higher dose, not to get too technical, it blocks the receptor site. Where at a lower dose, it kind of, the way I look at it, taps it just enough to stimulate your body to make these endorphins. Mm-hmm. So at higher dosages, it blocks it, but lower micro doses, it changes the way that it works in your body. That's why more is necessarily not better. You're getting a relief at a lower dose, that's the dose that you stay on. Yeah.
Now, I've always been in the habit of getting patients off of narcotics altogether before I prescribe it.
So I might have somebody on a tramadol once a day at bedtime. This has a very short half-life. It's 4 to 6 hours half-life. So if they're taking it once a day, I'll just tell them to take their naltrexone at a different time of day. Of course, if they're on a long-acting, you can't. It's more for patients who are maintenance on a pain pill, take it 3 times a day. Because now if you give the naltrexone, it's not necessarily the drug interaction, but if it's making it less effective and your body's used to having that medication, you could go through a withdrawal. See, but if you're taking something once in a while, we might be able to space the dosing so that you can do both, depending on what type of medication it is and how long it acts in your body. Yeah. Yeah.
If you take this medication for an extended period of time and you are taken off of it, or you feel you don't need to take it anymore under doctor's orders, is there withdrawal coming?
No, it's not an opioid. You can simply stop it. You simply stop it. There's no withdrawal. It's such a low dose. It produces such a wonderful, a great effect. I think when people call me and tell me, yeah, I don't think it's doing anything for me, I say, how long have you been on it? Well, it's been 30 days. It's not my biggest thing. I say you have to be patient at first, because like I said, it does come on very subtly in some people where you're questioning if you feel better. Or I'll have the people that's like, I didn't need this, I went off. And then they're calling me up, like, you know what, I didn't realize what that was doing for me. But that's the beauty, it's so low and the side effects are so low. I'm sorry, go ahead.
If you're going to have like a joint replacement, do you have to go off that medication?
I tell patients, if you're having surgery, I would stop it 1 to 2 days before surgery. And then once you're out and we know what pain meds you're on, we can assess how to take it then. When you're off the pain meds, you just resume back on the dose that you stopped with. So if you were on 4.5, so most people end up on 4.5 milligrams. So even then what I'll do is, instead of taking 3 capsules of the 1.5, I'll reach out to the doctor's office and we'll make you the strength that you're on. So you only have to take 1. It's just that initial phase so we have time to play with the dosing with it. And to continue, if you're on Plaquenil or a biologic, you continue that because it does take time to start working, and then you can assess it from there.
So when they take it in the evening, how long before bedtime should they take it?
It really, I tell people, I don't think it really matters, to be honest with you. The reason you take it in the evening is when you're sleeping at night, your body's healing itself. It's when the most endorphins are being made. We're trying to boost it. But again, my biggest thing is people are telling me they're not sleeping over time. I just tell them to switch it. But it really doesn't matter. Doesn't matter. Yeah, the guys have any? So
The other question,
go ahead.
can you take that with, let's say, a melatonin product?
Yes, you can.
You can
Yes,
safely?
you can. Mm-hmm.
Okay.
Yes, you can. You have any other questions?
I've like rarely not gone up like crazily, but gone up to 6 milligrams for some.
I have people on 6 milligram. I have. 6 milligrams is usually the highest that I see. The most common is the 4.5. I have people on a 2 milligram. It's so individualized. Here's the thing though, if you bump it up to 6 and they say they feel worse, then you need to back it back down. It's kind of a judgment call. They might need a little more, or maybe you're too high, you need to go a little bit less. So instead of doing a 6, if they're already on 4.5, just give them a 1.5 capsule instead of buying the 6. And you can just add that 1.5, they feel worse. It's so flexible then you could just give, 3 of the 1.5. You're not wasting medication that way. That's what I do. It up or down, it's kind of guessing with it, is what I've seen. Yeah. Any other questions? Okay, so should I talk about the pain creams? I think Camille was asking me.
For you, I don't know if you're going to any other offices for like GI, but have you found this to be effective with that?
I have seen it's funny because people say, it upsets my stomach and I'm having this going on, but that's just in the initial phase. But for colitis, it has been prescribed for any type of inflammatory condition that you can think of. It could be beneficial, yes, I have. Okay, so I have pamphlets, anybody's interested. So then that's the treat inflammation throughout the body. We also have our topical pain creams, and the pain creams are to treat your hot spots. And what we do is we'll do a full intake on the patient for their pain. So we understand it's customized for the individual patient. I don't have the same compound for everybody, gets something different. I drive everybody at work crazy, but everybody has something different. And when we talk to them, we're going to ask you questions like, what's your chief complaint? Where's your site of pain? Do you have numbness, burning, tingling? That tells me it's a nerve. You have muscle tightness. What type of you have inflammation? Are you on a blood thinner? If you're on a blood thinner, we're not going to give you an anti-inflammatory. All kind of questions. And we come up with a pain cream. Now, the goal of the pain cream is not to mask the pain. We want to treat the pain. We don't want it. Over-the-counter products may just make you feel good, but then they come right back. It's just covering up. We want to get to the root of the problem. So I tell patients, especially in the beginning, you want to use it consistently because especially if it's a nerve, nerves are stingy, you want to be very, very consistent. So everything's dispensed in our customized pump. This gives us accurate dosing. I'm not going to put a full pump, but one full pump is your dose. I tell patients you have to massage this in very, very well, okay? A good time to put this on is after a bath or shower when your skin is warm, because that always enhances penetration. We make this in our in-house lab. We make it from raw chemical. And I tell patients it's going to feel very smooth because we run it through machines, but don't underestimate the amount of medication. In other words, you don't have to wear gloves, but wash your hands real well after, because I wouldn't want you touching your eye or transferring to somebody else. When used consistently over time, it helps diminish the pain over time. But I will ask patients, what's your pain level on a scale of 1 to 10? If they say, well, I'm a 10, then we can put something stronger in there for immediate relief. So then the more you use it, it gives time for the maintenance chemical to start working, but provides immediate relief up front. But we do talk to you about this, talk to you about what you're experiencing, so we can come up with something that suits you. We ask you what you tried, what haven't you tried. There's a lot involved with this, a lot of time. And then we'll call you in before you're due for a refill to see how you did, because they could be tweaked. Remember, they're customized and personalized. So we'll call and see how you're doing. And if we need to tweak it, we will. Of course, we always have to reach out to the doctor to do that, but we'll do that for you. Yes.
I have a question. After a joint replacement, could you use that right afterwards on the site that was replaced, so you do not have to go on the pills that they try to give you after a joint replacement?
Well, it depends on the medication that they put you on. So here's the thing.
Like Celebrex.
As long as you don't want to put it on open skin. You don't want to put on any skin that's open. Otherwise, I would say you'll be fine once it's healed. Mm-hmm. Yeah.
And then does that cylinder that it's in, does that have like a pressure point where it goes down where you get all?
Yeah,
the
you could try.
material out?
There's no active ingredient in this if you like to try it. I like to use this because this provides an accurate dose. Because when it's put in a jar, you don't know how much you're using. And then it feels smooth, and now you're putting a lot of medication on you. So this helps control to get the right dosing. And if you
don't store that in the refrigerator.
room temperature.
Room temperature.
Yeah, and we'll
all the
always
time.
put on the bottle how to store it. We always put that. Room temperature.
Is that covered by insurance?
These are typically not covered by insurance. It depends on how many sites of pain, how much cream I have to dispense, and what chemical is in it. They can range 55, 85, depending on what we put in it. It's the how many sites. I can tell you that if you need more, I tell patients, like some patients will say, you know what, now both my shoulders hurt. I need double. It's not double the price. There's a substantial savings when you need more. So I tell them, if I see somebody's refilling it frequently, I'll say, why are you refilling it? Well, I'm using it on both knees. Well, okay, let's get the script for both knees. Let's get you the amount of cream you need, because it's really not that much more. There's a substantial savings. I try to be very conscientious with price with that. And then we ship too. We ship throughout all, we're licensed in PA. We can fill for any state, but we can't ship, we can ship into only Pennsylvania. And there's no charge for shipping.
And how long should one typically last?
I do 25 days. The reason I do that, there's a use by date of 30 days. It's a soft expiration is what I call it, because they're customized. So they're not sent out for long-term studies for expirations. So I do 25 because if it has a use by date of 30 days, it gives me time to ship it and it's still within date once the patient receives it. That's why I do a 25-day supply.
So what if you don't have to use it every day? You just use it intermittently?
I have people that do that. So at first, I do that with a lot of people. So I tell them, use it consistently at first, and then you know your body. Some people will tell me, now I'm fine, I only need to use it once a day. So I cut down on the amount of cream that I dispense in the month because we know it's going to eventually expire. So if I see that you're getting a late refill, because we follow up on all our patients, why are you well, I'm only using it twice a day. Oh, you having pain relief? Yeah, twice a day holds me. Okay, well, maybe you don't need as much next time. And so we'll work with you.
Does the price vary then if you refill it for, like, if you're giving you less material than what you originally?
Oh, if it's less, oh yes, you'll pay less.
Okay.
You'll pay less for that.
So what is the expiration usually?
So it depends on the base we put it in. The base that I use, it's a use by date of 30 days. I can put it in an anhydrous base, which is nice. That means there's no water in it. And I can extend it to 6 months. I can do that for you. It's not as aesthetically pleasing. It's not as creamy. But if somebody really wants it, we can do that. It doesn't feel as nice. And we want it to feel nice to put on. So that's a regulation, is 30 days. Unless I have some formulas with extended studies. We do have some with extended study. There's a small database that I could pick one with an extended study with this nice creamy base that might suit you.
Would it be harder to spread if it had a 6 months expiration date? Is it thicker?
It spreads. It's not as smooth feeling. It's hard to say. Because there's no water in it. There's no water. These bases have water. That's why they have an expiration date like that. When you take the water out, they're a little stiffer feeling.
Grainy?
Not grainy, just more stiffy. Yes, if that's the word I'm looking for.
Okay.
Yeah. Yeah.
Might be a dumb question.
No dumb questions.
But like, let's say someone was trying like we put like a gabapentin
Okay.
cream and it didn't work. Would you ever substitute naltrexone?
We
Have
have,
you tried
we've done
doing that
topical
cream?
naltrexone.
Yeah,
I've done, but gabapentin's more for nerve.
yeah,
So you mean they just said it didn't work at all?
yeah.
So I would ask them, are you using it as frequently as you should? Are you massaging it in well? Nerves are stingy. Like I would probably tweak the formula, because when you do topicals, I could put 2 nerve medications in. We could go very concentrated, because remember, it's not going through your liver or your kidney. We're avoiding first pass. So we can go very, very concentrated at the site. So I would probably add maybe a second nerve medication, maybe some magnesium in it. I would tweak it.
What have you seen the naltrexone topical used for?
The naltrexone topical psoriasis, I've seen it used for psoriasis. There's some speculation with hair growth, because if you have an autoimmune, your scalp's inflamed, you treat the inflammation, it helps with hair growth. I do have a dermatologist writing the oral capsule to help with hair growth. Yeah.
Really?
There's a lot. Yeah, there's a lot involved with low dose naltrexone. But
you put it in a
psoriasis is a big
shampoo?
one. We could put it in a shampoo. We have shampoo bases. But here's the thing: if you're using the shampoo, it's ever not on the scalp. It's not. It has to be. You'd have to really massage it in your scalp. So what I would like to do, and I have it on my table. I should go grab it. I have a nice foam for the scalp. It's a pump bottle. It's a foam, and it adheres to your scalp. You put it on at night. It feels so nice. I think he went to grab it for me. I actually brought my foam.
with minoxidil, and it comes in a
The
foam.
foams are beautiful
The
for the
foam is
scalp.
fabulous.
It is, because
'Cause it's
cream's messy for your scalp. It's messy. So anytime we're doing hair growth, I always go foam.
So is that a better product than Rogaine?
It's a different product. Let's just put it that way. They work differently.
Because nothing has changed, and I take also Propecia
Okay.
to the pill.
Okay.
Not the full dose, half the dose. But the hair dye, I'm a hairdresser, so
Okay.
I realize what's going on. with me.
Yes.
The diameter of the hair has never changed. It thinned out to be very fine,
Oh, you're the best.
and it has not increased it.
It depends on what is your diagnosis, why you're having
Heredity.
alopecia. It depends what it is. Is it hormonal? Is it due to an
Probably
autoimmune?
all that.
So if it's due to an autoimmune, then that naltrexone theoretically should help you. If it's hormonal, we might have to go a different route. So this is how I'll pass this around, because this is how the foam feels. Here's the foam. We can put anything in the foam. I've put in gabapentin in the foams for people. Some people just like it in a foam. Gabapentin, amitriptyline, lidocaine. I have one that the dermatologist uses. We're very creative with compounding. We can compound anything as long as it's not commercially available. Then we can compound it. Those are the foams, and this is the cream. If you want to, it really just feels like this, the creams, because we run it through machines. See how that would go on, adhere to the scalp. It's not greasy.
That's right.
It has just a thin film. Thank you, over the scalp.
It's thinner than the Rogaine. The Rogaine foam is thicker. This is thinner. It has a
Yeah.
nice consistency.
Mm-hmm.
Is there anywhere that you wouldn't?
If it works, I'll do an ad for you.
Anywhere.
With topical steroids, you have to be careful, like with the face.
Not honestly, I couldn't think of anywhere now, because the topical steroids over time can thin.
Yeah.
But you don't have that. No. We've used it pretty much everywhere. I'm just saying. So, any questions on the creams? Any questions?
Now, what
I'm
is
thinking,
the-
did I go over it
What
enough?
is the product that's in for the hair growth? What is it?
Okay, so I actually have. We have several formulations. I even have a metformin topical foam we're using for hair growth. We have a whole database. again, we'd have to talk to you. We're your doctor as well. It starts with your physician, and then we can help recommend something. But it depends on it depends on what's causing it. Yeah. I'm trying to think of more off the top of my head. I have a whole prescription blank of cosmetics, and I have hair growth on there. Finasteride,
So
but you have to
you
be.
use a different hair growth for men than women?
No, not necessarily.
No?
Not
So
necessarily.
you actually have the finasteride that you could put on top
We
of
do
it?
that. We have to be careful in females with that. But yes, we
I've
have
heard
that.
that works rather than the pill.
Yeah, we have it where it's topical, so now you're putting it all again right at the site instead of going through your whole body where you don't need it.
Then you would cut out the pill
Yes,
because it would be too overdose.
in most cases, yes. Yes. Do you want to hear about this saliva test? I'm on a roll, so okay. So the other, our compounding pharmacy, we do suppository suspensions. Rectal rockets for hemorrhoids. We have all kinds, but these are our highlights. So we do saliva testing for hormones. And this is more for perimenopausal, when you're starting to get into menopause. You know you're getting into menopause when your menstrual cycles are becoming erratic, maybe not every month, and into menopause. The best time to, if you were going to go onto a hormone treatment, would be within no later than 10 years of menopause, unless you've been exposed to hormones since then. So the hormones that we use are what we call bioidentical, meaning that they come from natural sources and your body recognizes them. So I like to call it hormone restoration because it enhances your hormones. Whereas when you take a synthetic, man-made, sometimes your body will stop making as much as it normally produces because the manufacturer or the synthetic is taking over, whereas this enhances your natural hormones. It's not foreign to the body. So if you're going through menopause or perimenopause, and most women experience different symptoms, but a lot of us experience most of them, hot flashes, night sweats, tired, low libido, anxious, it could possibly be your hormones. And the way that we test that is through your saliva. So there's two ways to test your hormones. You can go through serum, which is your blood, or you can go through saliva. What we find in serum is it's protein, what they call protein bound. So even though you might have a decent level in your blood, it's bound by this protein, meaning you might not be able to absorb it as well into your tissues. That's why I like saliva. It's not protein bound, so it's better reflection of what your tissues can absorb and what's available. That's why we go saliva testing. Saliva testing is very simple. I have these kits at the store. The hardest part, it's a spit test. The hardest part is filling up the tube with the spit. That's the hardest part, okay? See, yeah, I did it took me at least a half an hour. So you do this first thing in the morning. I have instructions. I'll go over it with you before you do it. But basically, it's when you first wake up, nothing to eat or drink. Fill this up halfway without bubbles up to here. This is going to measure estrogen, progesterone, testosterone, DHEA, which is a precursor to testosterone, estriol, and your morning cortisol. So it's all your hormones and your morning cortisol. Cortisol is going to tell us about your adrenal health. And then you have 3 more tubes throughout the day. Noon, evening, and bed. Now this is smaller because the rest is just your cortisol levels. So this is a 4-point cortisol test, which I like the 4-point. We can just do the morning tube, but then we have no idea what's going on with your adrenal glands the rest of the day. So if you're going to do it, I think we should have a big picture. So you fill them up, you name and date on the tube. Included in this is a questionnaire. And I tell people, take your time filling out this questionnaire because a lot of hormone symptoms overlap one another. And that's why I think it's important to do labs before considering HRT and not just doing it on symptoms because they overlap and you don't want to overshoot one hormone and not have enough of another. So if you fill this out at the end of the day when your test results come back, we're going to get these nice little graphs, and I'm going to pair your answers to your actual test results, and now it all makes sense. So we can see you're having several symptoms that are pointing to maybe a low estrogen, and this is validating that your estrogen is low, so now we know what direction to take. So once your labs come back, by the way, after you do your spit test, you just simply put it in this mailer. It's a prepaid mailer, but they give you a mailing slip, mail it in. I'll get the results in about a good week or so. When that happens, I'm going to email you and say, hey, got your test results, when you're available to talk. And I'll email you your results, and then we'll talk on the phone. And then if you're a candidate for HRT or maybe adrenal support because maybe your cortisol levels aren't optimal, then I will reach out to your prescriber and I'll send her the consultation we had. I'll send her the full everything we talked about, and I'll send her the recommendations for consideration for HRT. And this is an example of an HRT cream. Now, there's no active ingredients in here. So we dispense them in something called a TopiClick. We use this again for accurate dosing. And on your click, it'll tell you what your dose is. It might be 1 click, it might be 2 clicks. Sometimes it'll be 1 because we always start off slow and low. And then we'll see how you're doing in a month. And then if you're like, you know what, I feel better, but I'm not quite there. Okay, you're ready for 2 clicks. So that's another flexibility in dosing that we do. So when these come back and you talk to me, you're not done with us. Like, we're going to call you in a month to see how your symptoms are. And then we base it all on symptoms for about 6 to 9 months. And then we ask for another saliva test because we want to compare it to baseline to see where we are. Because we want to stay within normal physiological dosing. If you go too high, then you're going to have different symptoms. We want to keep you where you're supposed to be. So we dispense them in these TopiClicks. Never use your hands, I tell them. That's why it's rounded at the top. You put it on thin skin, okay, and you want to massage this in until it's in. If you're supposed to do 4 clicks, I say do 1 click at a time to really make sure that you're getting that in. Rotate sites. And I'll tell you this when you're getting it, but behind your knees, inner thighs, your wrists, any thin skin, you want to avoid the breast area. If you're going to be around children, I tell patients, put it on skin that's going to be covered by clothing because you don't want to be transferring this. So these are one of our devices that we use. Another cost savings that we try to do, if say you need progesterone and you need estrogen, I'm going to put it all in the click for you because that way you don't have, 3 or 4 different creams to use. Although sometimes we'll recommend an oral progesterone. I obviously can't put that. That's going to be a separate script because you might have symptoms that constitute that might be better for you. But we will look at all that and we'll talk about all that because everybody's different. We also have, this is called a meter dose pen. This is typically what we put our testosterone in. If you're low in testosterone, you could be very fatigued, tired, not motivated, loss of muscle mass. Usually we'll start with the DHEA because that'll help boost your testosterone, but if you're really low, we might add this at first. It's another meter, it's locked, still locked. That's about how much it is. And again, you would rotate sites. This is our testosterone. Some people just get the testosterone, so we put them in these because it's very concentrated. You might be recommended a vaginal cream. So we'll tube it up for you. You have an applicator. The applicator screws on the end of the tube, and then now it's a vaginal cream. All depending on the person. Everybody's different on what they're going to get.
I went to a chiropractor, and he said, like, if you were through menopause and whatever, that he had, in fact, I used it, a progesterone cream that you just put on it.
Now see, there are over-the-counter progesterone creams, and I don't have a problem with that. The only problem I have with that is 2 things. You're guessing based on symptoms what you need. So now if you have more progesterone than estrogen, you're going to start having symptoms of progesterone dominance. So you're kind of like doing a guesswork because you're just doing it on symptoms. and they're not put into these devices for accurate dosing, and
It
you
was
don't know how
in a
much you're
pump.
getting. That's the, oh, okay, so that's in a
It was
pump.
Yeah. it
I
was-
saw some in an ointment jar, and I was like appalled when I saw it.
Yeah, this wasn't an over-the-counter thing. In fact, I had my pharmacist
Oh,
compound it.
okay, so, okay, that's fine, that's
Yeah.
fine.
But like I had none of those tests done that you're talking about.
Most women, postmenopausal, we know we're low in progesterone, we know we're low in estrogen, we just don't know how much. We don't know where we are. And some aren't, and like again, you're guessing on symptoms, then if you overshoot one and not enough of the other, now you're going to get into different symptoms. So we kind of want to, this helps us keep it in harmony. It should all be on the same playing field. It should all be leveled out the same. This helps us keep it all balanced.
Well, doesn't hormone imbalance cause hair loss too?
It can.
The factor?
It can.
So many things to consider.
So many things. That's actually one of the questions on the questionnaire. You're having hair loss. So then we're looking to see, okay, she has hair loss. Let's see what's going on. See, it all tells a story. When we look at this, it turns into a story. Then I'm going to have questions when I look at this to ask you when I call you, so we can understand it better. And also, the lab that I work with, I work directly with the providers at the lab. They see thousands of tests, and I'm talking to them all the time. Basically, most of the ones that I do, we'll touch base with each other on, okay, because there's more than one way to do things. This is how I would approach it. Well, how about this, how I would, and then we collaborate, and now we're sending it to your doctor, who's another professional looking at it. So you have 3 different providers looking at your results. Yeah. Any questions? Anything?
Very complicated.
It can be, but when you break it down, then it's more simple. You just have to break it down.
They unravel it.
Yeah, we'll break it down with you. When we call you, I'll say, look at this, now look at that, this is what this means, and yeah. It's a lot when you hear it all at once.
Yeah.
But it really isn't.
It's amazing how they used to medicate compared to now.
I know.
One pill for everybody.
Let's say we do the serum testing here.
Okay.
And you have low DHEA. Can we refer to you?
Oh, absolutely.
Would you order this, or would you?
If they have a low DHEA, if you start them on a DHEA supplement, which I have, it could actually double your testosterone level. So we usually, with a low DHEA, we'll just start with DHEA 5 or 10. I don't go too high.
Okay.
And you can send it over as a script, because I do have it if you don't have it. Because we have a dispensary online that carries professional supplements. I only do a capsule form, like only certain brands. I'm real fussy with it. But yeah, that's the first thing I'll start with is a supplement. But then if they have other symptoms, hormone system, then I would refer them over.
Yeah.
The vasomotor symptoms, the hot flashes and night sweats. Or maybe they have adrenal symptoms. We did that one, and that was right on the money, tired all day, generally feeling run down, can't sleep at night but exhausted, something like that. We might just want to do an adrenal test. So
Is it covered under insurance, or is it
it's not covered on insurance. That's the downside of it. Now I do have people that use their flexible savings account for it.
Oh, you can do that.
You can use your flexible savings account, but it's not.
the saliva test kit?
The saliva is not covered. So if you get the 4-point cortisol, it's $220. We can just do the hormones in the morning, and a morning cortisol, it's $150. But a lot of times your cortisol could be okay in the morning, but then we don't know what's going on through the day, so now we're guessing on your symptoms. I really recommend for the first time to do the 4-point, because a lot of times I see normal morning, but their nighttime's super high. You don't know what's going on then. And it helps us on what we can recommend.
How much is the cost for adrenal zoning?
The adrenal one, I think the adrenals maybe $125. Yeah, do the adrenals, and then test that in your DHEA. Test that in your DHEA, because your DHEA is low,
Would
more
that
likely
be
your
included
testosterone is
with
low.
it?
That's included with the adrenal test, yes.
Test, okay.
Yeah, that's
So if
included.
you can't take the hormones, you might be able to.
You can
correct-
do the adrenal stress test,
Oh, okay.
yes.
Is that the saliva thing?
It's
too?
also a saliva test, and Well, no, that's 4 tubes too. I thought you were going to get lucky and it was only one, but we do a 4-point, yeah. And I said the really nice thing about these tests too, you get to talking to people. Like for example, I had a patient and we were looking at her and we're like, wonder what her, it was a fertility test. And we were like, I wonder what her insulin is. So the lab keeps your saliva for a good 2 weeks after. So I was able to call up and say, let's do an insulin resistant test. Like I was able to add labs, which was, I think that's really nice. Or, you know, that's just another option. Or if you want to test another hormone, they still have your saliva. So we want to take it a step further. In some cases, not all, but sometimes it comes up. We have the option that we can do that.
You know what, they talk about this insulin resistance thing. What do you do, what is it, and then how do you correct it if you have it?
I think who could help you more with that would be Rose, with the insulin resistant. Rose could really help you with that.
The dietitian.
Oh, okay.
Exercise, they say after you eat dinner, you should go for a 10-minute walk.
So there's no pill you take for it or powder?
In extreme cases, yeah, it depends on your levels. In extreme cases, but not always. But Rose would be a good one to go over with you with that.
So there's a test for that too?
Well, they do, yeah, you can test for insulin levels and see peptides and everything. You know, it's more related to the pancreas and
You could have that but not be a diabetic, right?
well, that's pretty classic for metabolic syndrome is insulin resistance.
Mm-hmm.
Like if you have hypoglycemia, would that play into it?
It's hard to say. Yeah, but it possibly, I mean, you could be bouncing
It is hard to say. Yeah.
because, you know, if you're hypoglycemic, the adrenal kicks on and it tries to put out more cortisol to,
Yes.
you know.
Oh, okay, that explains a lot of things.
Mm-hmm. Mm-hmm. So if I have my cards, if anybody has any questions later,
She said
something
she
comes to
got
mind,
cards
just
and brochures and
yeah, just
everything.
call me. If something comes, you think of a question later, I have my business cards, I have my information on the back of the pamphlets. Feel free to call me.
Great brochure, thank you.
So
That was past due.
you're a
I had to get.
pharmacist?
I'm a pharmacist, yes.
Do you have a PhD or?
Nope, I'm just a pharmacist. Yeah,
that's
Bachelor
a
of
lot.
Science in Pharmacy.
That's a lot of education
Yeah.
to be a pharmacist.
Yes, I've been doing it now for almost 30 years.
Really?
It's hard to believe, yeah. Long time, too
You
long.
must have started doing that when you were 10, huh?
Too long. Don't know about that, but oh, thank you.
It was great.
Yeah.
Oh, thank you for having me.
So anyway,